Anissa.
Anissa.
Hi,
Sorry
Dara.
about that. Hi, hey. That's a friend of mine. Hey.
I didn't mean to disrupt, but she was like, "Do you know Dr. Mendez?" I was like, "Yeah."
Hey, good to see you. Small world, see?
No.
Small.
She was like, "Do you know Dr. Mendez?" I was like, "Yeah."
Hey, good to see you. Small world, see?
No.
Small.
She was like, "Do you know Dr. Mendez?" I was like, "Yeah." Okay. Well, my name is Lisa. I go by she, her. Yes, my interests would be pharmacy, and my focus project with Hillman is modeling female pelvis and pelvic organs.
Thank you. Alexandria.
Hi, I'm Alexandria. I go by she, her pronouns. My interests, I'm still figuring it out, but right now really medicine and maybe government. And the focus of my project is on using EEG-based BCI data to expect and predict distress in individuals with autism spectrum disorder, and then one day use that to treat it.
Great, thank you. Good to see you again. Eduardo?
Oh yeah, my name is Eduardo Ramirez. Go by he/him. I have an interest in neuroscience, and the focus of my project is using machine learning to find gene signatures related to tumor development.
Thank you. Marcus?
Marcus. I use he, him pronouns. I'm interested in biology, medicine, and health. My project is looking at the percentage of stromal and immune cells in a tumor and how that influences the outcome of immunotherapy.
Thank you. Jonathan?
Hi, my name is John. Pronouns are he, him. My interests are in mathematical modeling and computer science, so like programming. And my focus on my project is utilizing mathematical modeling to model the PI3K pathway.
Great, thank you. Pablo?
Hi, my name is Pablo. I go by he, him pronouns. My interests are generally engineering and computer engineering specifically. And this summer at Hillman, I'll be working on applying machine learning and deep learning to brain MRI data of Alzheimer's patients.
Great, thank you. Amanda?
Hi, my pronouns are she, her, and my interests are in biology, music, and politics, and my project is curating estrogen receptor data and creating algorithms that will help to create an estrogen receptor next generation sequencing database for the breast cancer community and field.
Great. Thank you. And then Jenna. Great.
Hi there, my name is and my pronouns are she, her. I'm interested in medical and lab technology. And I'm also focusing on the deaf community and providing access of science to the deaf community. So what that means is making sure that individuals have that information translated into ASL.
Great, thank you. Did I get everyone? Did I miss anyone? David, did I get everyone?
I think everyone. Eduardo, did you speak?
Yeah, I spoke.
Okay,
Yep.
I think that's everyone then.
Okay, great. Thank you. I appreciate you sort of indulging me and sharing a little bit about your background. It sort of helps me as I, walk through this discussion with you. So really today, I wanted to share a little bit about my journey. Taylor thought it would be helpful for me to just talk about how I got to the work that I'm doing now. So sort of those twists and turns and things that happened along the way. Obviously, this is not a full out memoir, so I won't go into every detail, but hopefully I can just give you a little bit of touch of sort of some of the decisions that I made throughout the process and why. And then I'm just going to talk briefly about what is public health and health disparities. This is meant to be introduction and a bit of an overview. I won't get in really deep on my actual, research and scholarship, but my contact information will be at the end of the slides for anyone who wants to hear more. I'll also share really briefly, I have an equity scholars program that I run through the department. It's more of an informal program, but it's an opportunity for scholars from high school actually all the way up through early career faculty to meet to talk about their work. And it is central around sort of reproductive health, sexual health, maternal child health, although we have scholars who are interested in health equity, generally speaking. So I just want to share that as well. So my journey. So obviously there's a lot of twists and turns in any process that we go through to kind of move from one stage to the next, whether that's in our career or our personal lives. So I wanted to just share a couple of pieces. So one of my first formal research experiences was in high school. So similar to you, I knew I was interested in science, did really well in math, but I also had a sort of core component of myself that was interested in pursuing art. So at the time I had been engaged in community theater arts, modeling, and a little bit of acting, not much. And so I always sort of had this thought of, at one point I'd be able to combine those pieces. And as a high school student, we were required to do a research, almost like a thesis that you would consider in an undergraduate program. And that was my entree into research with the Sickle Cell Society of Pittsburgh. And that first research experience really, I think, grounded a lot of the work that I do now as it relates to centering Black and Brown voices and the work that I do, especially in understanding health equity. At the time, I also worked closely with, researchers and mentors at Penn State during a summer program, similar to what you're doing. This is through the College of Health and Human Development. And at the time, I worked with a faculty member who I, still sort of keep in touch with now, which was focused on, looking at environments and how that contributes to health long-term. So at the time, I didn't know what public health was, but I was already engaged in public health work. And I'm going to kind of explain that sort of process. Then I went on to college, went to Spelman. And as I mentioned, considerable interest in health. But I really wanted to look at other pathways, but wasn't sure how to do that. So I started out biology major, pre-med, I'm going to go that route, perhaps medicine. And I had multiple experiences that really opened my eyes to wanting to be in a place to prevent disease and adverse health, which is a core component of public health. I actually was a house staff assistant at Grady Hospital. This is like one unique experience that really stands out to me, where I was shadowing, the residents, the other docs, and a lot of them were in training. I was just there to volunteer. And, in that one day, and so Grady is a public hospital. And so in that one day, I saw a myriad of cases from every health concern you could consider. Grady is also a public hospital in the center of, in the heart of Atlanta. What I also saw was a disproportionate burden of health and disease among people that looked like me. And I felt like I wanted to be part of, the structures that prevent that, right? Not just kind of addressing the issue as it was happening, but to prevent it, right? But one day in particular, shadowing, working with, the house residents and other practitioners, and I passed out. We were actually in one of the examination rooms, working with them. There was a particular patient who was overdosing, and so it was very tragic, circumstance and situation. And I passed out. And for me, just the process in that day of seeing the multiple adverse health issues that were affecting multitudes of people, predominantly who looked like me, I really felt like, okay, I need to think about what are some other ways to do that. At the same time, though, I thought, I don't know what other examples to go by. Like, if I'm not going to do medicine, what is it? If I'm, maybe I'll do research, maybe I'll do something related to science. Still shadowing, working with physicians, getting that hands-on experience, also doing summer research at Purdue University and in Jamaica through a summer science research program. And then at that point, within that process, decided to actually change my major to sociology anthropology, because I really felt like having that exposure to what are the social dynamics that contribute to health, which many of you know of social determinants of health, which I'll explain a little bit, was more in line with what I needed to do and wanted to do. Wasn't sure what that would look like even still. So I pursued, tried to pursue medicine, took the MCAT and like literally bombed it. I laugh because I was actually doing a summer program in Jamaica, and my mom called me. She's like, "I got your MCAT results." And I said, "Oh, great." She was like, "Is this your total score? Just one section?" I said, "Is it that bad?" And lo and behold, medicine, practicing medicine wasn't meant for me, but I kept pushing because I thought that's what I should do, right? That's what I knew. Also at the time, I completed a thesis called External Internalization. And I look back on the work that I did as an undergrad because that actually was the pipeline and sort of the lead into the work that I do now, which is really looking at how these intersecting systems of oppression, whether it's racism, classism, sexism, contribute to adverse health. After college, still not sure, will I go maybe pursue medicine, maybe not, worked in research. And at the time I was on an evaluation team with a specific program called Children's Futures through an organization, Public-Private Ventures, that no longer exists. And so this evaluation firm would typically work closely with community organizations. And at the time, the work that was being done, I thought was, really novel. It was taking a place-based, multi-sector approach to addressing children's health, infant health, and even maternal health. But the thing that I saw was many of the communities disproportionately affected, because this was an initiative in New Jersey. I lived in Philly at the time. Most of the folks making the decisions didn't look like me. And that was frustrating. So I said I needed to go back to school. I wanted to be in the position to make the decisions, coming from my own lived experience and knowing that the way that things were being done weren't really attentive to what were the needs of those communities. And so pursued graduate degrees, both in maternal child health and epidemiology at UNC, as Taylor mentioned in the introduction, and really, moving the work forward, both in research practice, but also in policy. So just in the interest of time, I'm going to skip through. I just wanted to briefly mention some Pitt graduate school public health opportunities that you all might be interested in. One is the 4-1 program, which Taylor can speak to. She can probably answer all your questions during the Q&A about that. But basically it allows for students who are completing their degrees at Pitt to carry on to complete an MPH at Pitt. And then now there's the Pitt to Pitt program, which is also a pipeline, particularly for students who have just finished at Pitt to continue their education through graduate degrees in the school of public health being one, multiple other programs. So I want to ask you all, this is where we kind of get into the interaction. What is health? Anyone? What is health? I know it's a little odd to do this on Zoom. Yeah, go ahead. Anyone jump in?
Maybe it's like well-being in a wide range of aspects, like mental well-being, physical well-being, and like making sure that well-being is it's very equitable.
Mm-hmm. Right, so you cover quite a bit, right? So these multiple facets. And this is just one definition, which is the World Health, the state of complete physical, mental, and social well-being, and not merely the absence of disease, right? So it's not just you're not sick, but what are the things that make someone whole in terms of health and well-being? So that's one definition. So what are some of the things that contribute to health or optimal health? Julian? What are some things that contribute to optimal health or health in general?
One thing that contributes to optimal health is that it's available to like everyone. It's equitable. Like the same health is available to anyone, regardless of like how much you make, like what like different things you might fit into. Like being easily accessible, and being able to learn about benefits or some things you should do without having to pay a lot of money, like having like just being able to know certain things, having to go to an appointment, have your doctor like say one thing, and then it costs like $500.
Mm-hmm. Absolutely. So you're bringing up the economic, factors that might contribute to optimal health. You're bringing up accessibility. I heard a little bit of like communication, perhaps with a practitioner or physician, perhaps. What are some other things that you think contribute to optimal health? You think about your own health. What are some things that contribute to optimal health? Erica?
I was thinking maybe like in regards to like an environment, like a very comfortable environment, whether that be just in general, like relating to your personal health or relating to like feeling open to communicate with your practitioner and stuff. Sorry.
Mm-hmm. Right, so she's talking about the larger environment. Right, anybody else?
I guess you could or like how the choices you make and how those come into your health.
Mm-hmm. Great. All great examples. So what is public health? Can I just see maybe a thumbs up or show of hands or, any kind of signal that you can do on Zoom of folks who are familiar with public health? Thumbs up, about half of you, right? So what is public health? I know many of you may be familiar with medicine, right, as a discipline, as a field. Obviously, public health related to that. But what is public health? Julian, were you going to answer?
Oh, sure. It's like keeping a community like well, like healthy, like preventing diseases, like making sure everyone's like safe and has access to medicine, like proper medicine.
Great, thank you.
This is Taylor. Sorry.
Go ahead, Taylor.
No, I was going to say public health was more of a population level focus, and it also deals with interventions to prevent diseases.
Absolutely. So you read that. No, just joking. So I know Taylor, obviously, as a student entree into public health, as she mentioned, really we're thinking about the larger systems at play. So, public health promotes and protects the health of people and communities. We talked about environment, right? We live, learn, work, and play. And it ranges, right? There's a number of things that I think are touch points when we think about public health, right? It could be scientific research. Some of you are engaged in, I would say, research that has public health implications or implications for populations. Educating about health, looking at the conditions. I think I'm heard a couple of people talk about policy as well, right? So if we were to think about your day, think about the day in the life of, right? Your day, the day in the life of Erica, the day in the life of Jonathan, the day in the life of Samuel, right? If you were to walk through your day, there's probably most things that you do have a either public health implication or connection. A lot of what we think about as it relates to larger environment and things that influence our health do have public health implications, right? Sometimes we think about health and all or health and all policies, where the things that we do, the things that we're exposed to or experience have a health implication to it, right? So I'm just gonna pick someone if that's okay. And I want you to walk me through your day. Jonathan, walk me through a typical day. Now I know with quarantine and COVID, like our typical day is not a typical day, right? It's very much shifted. But if you were to think just generally, first thing you do when you wake up, next thing you do, where do you go? Walk me through a day for you.
Usually I wake up at like 11, and then I brush my teeth and make breakfast.
All right, let's stop there, right? You brushed your teeth. So what did you use?
Toothpaste.
Right, what else?
Water.
Water.
Green.
Right, when we think about public health, we think about fluoridation of water, right? We may not think about it when we're brushing our teeth, but in many cases, we are in communities where fluoride is infused in the water. And why would be fluoride in the water? What's the purpose of that?
It's good for your teeth, right?
Right. It's supposed to, right, help with, you know, dental caries and, you know, dental health, right? But then we're also using the water when you turn on the faucet, right? And this is where inequities also, you know, play a part as well in terms of water quality. But when we think about our water systems, we have a public health and environmental infrastructure that is supposed to ensure that the water that we use and ingest is safe, right? We know that there are, you know, stark disparities in access to water, right? Flint, Michigan being one example, and even here in Pittsburgh or Allegheny County, right? So those are public health key elements. Then you said you eat breakfast, right? So you might think, okay, food guide pyramid, right? That's a public health intervention that has more to do with sort of thinking about education, but we also think about our food systems. At every step of the way, there is a public health component, not only to policy, but how we are able to receive our food. One of the very first governmental federal nutrition programs was actually based on work from the Black Panthers, right? When we think about the public health implications of food, where we get it and how we have access to it. Also inequities with respect to access to food, distribution of food, and healthful foods as well. All right, so he started off in the morning. Somebody want to continue on? What's the next thing you might do? Anyone, jump in. Or Jonathan, if you want to continue that, or John, anyone.
So then I usually go to my Zoom call for the Pitt program. Then I log off and just do work for the rest of the day.
Right. So prior to COVID, we might be driving to work or taking some kind of form of transportation or even walking, right? So when we talk about built environment, right, that's also key and critical when we think about public health infrastructure, right? When we think about the Clean Air Act, right, and diesel emissions, right, from vehicles or public transportation, that's also clear public health implications there, right? So we're talking about the environment, we're talking about nutrition, right? When we think about even some of the statistics and things that you all were talking about with respect to the machine learning algorithms analyses that you are doing, those who are in the fields of biostatistics and epidemiology, right, other fields within public health are also engaged, right, in this work. So this is just to give you some sort of concrete examples of how public health interfaces, and there's many more, right? I could go on and on, right? So these are just examples. This, once again, is from the American Public Health Association, and this lists some of the fields of public health. So, you know, many of you are conducting research, right? So that's listed on here. And several of you talked about the policy implications of the work or the community level implications of the work that you're doing, right? So these are just some examples of what that can look like, right? And many touch points with respect to the things that we do on a day-to-day. So what about health disparities and health equity? Just show of hands of folks who are familiar with these terms. Show of hands. Either one, yeah. Right? Or you can do, if your screen's not on, you can do your thumbs up, right? So many of you are either familiar with or have heard these terms, right? So I just want to walk through a couple of them. Now, when we think about the word health disparity, it's a very, I would say, common word used now in medicine, in public health, nursing, other health-related fields, right? And this was first used early on, I would say 1990, even prior, but we had sort of a concrete definition of disparity, right? And in those earlier sort of definitions of disparity, a lot of the work in the United States really focused more so on a difference. Like we see a difference, but without any direct language around why that difference exists, right? So you can say there's a difference between one group or another with respect to a health outcome. For example, I do work in pregnancy outcomes, infant mortality, preterm birth, without necessarily implying why those disparities exist, right? Globally, though, the conversation around health inequalities really focused on, these larger systems that were avoidable, unnecessary, and unjust. When we sort of fast forward to what we consider more of a contemporary definition here in the United States, specifically from the Healthy People 2020, this goes a little bit deeper into thinking about not only that there's a difference, but why that difference exists, right? Closely linked with social, economic, and environmental disadvantage, adversely affects groups of people who are systematically experience obstacles. And then if you sort of go to the end, that's historically linked to discrimination and exclusion. And we can think about oppressions as well. Right, when we think about health inequity or equity, right, is looking at health for all people, right? If we're looking at not only the unfair conditions by standards of social justice, but ways in which we can eliminate them, right? So here's just one graphic. I would say there's no one perfect way to articulate this in pictures, and there's been a lot of back and forth on, you know, sort of what is the best way to try and capture this, but this is just one example. Right, so this is actually, this picture comes from the Robert Wood Johnson Foundation. I don't know if you can see the citation on here, but you know, equality is giving everyone the same thing, regardless of anything else, right? Regardless of circumstances, environment, et cetera, right? And equity is providing what is needed for either, in this case, it's the individual person, but we can think about this from the public health population standpoint with respect to how this relates to the needs of a group or population, right? This is one that some of you may have seen that is, you know, very prominent in both the public health space and medicine space, which sort of drives home a similar point in terms of equality versus equity. And then reality, which I think gets a little bit into the historical context, right, as to why we're seeing this, and then liberation, right, eliminating all obstacles and systematic barriers. So this just quickly gives you a little bit of overview of some of the definitions. You have the health disparity, right, looking at disproportionate differences in equity, which is really pulling out things that are systematic, unfair, unjust, right, social justice also within that. And then health equity, a fair, just distribution of resources. And in this work, we can think about sort of these 4 tiers. I like to say, you know, these tiers, I think, help us think through ways in which inequities exist, but how do we tackle them? And I want to end a little bit with work around critical race theory, public health critical race praxis as it relates to racial disparities, right? So tier 1 are what are the inequities? Most of you are probably familiar. You know, perhaps in the work that you're doing, a specific health, you know, outcome or health issue that you're focused on, you could probably quickly cite what the disparities might be, right? You are experts in these different areas of cancer, but I'm going to give you a few examples in my space as it relates to maternal child health. So this is data for our county, and this is pregnancy and birth outcomes, and this is specifically among Black and white women. Although we can look at disparities from other racial groups, but I wanted to share this example, right? And this is not new data, like this is obviously some historical data, but very similar to what we see across Pennsylvania, similar to what we see in other cities around the US as well. But here in our county, we have a stark disparity in infant mortality or infant death within the first year of life. Preterm birth, which is considered sort of early gestation, if you will, low birth weight, and then maternal mortality, which is death of a person who's pregnant within the first 42 days of either termination of pregnancy or delivery, right? And so we see also a stark disparity in maternal mortality. And for many of you who are interested in sort of maternal health or just health in general, may be familiar with some of these statistics, especially on a national scale. So this is COVID, right? So we're in the midst of a worldwide pandemic and epidemic. And for many of us who have done equity-related research, we're not surprised by the disparities that came out, not long after, the initial conversations around COVID, the lack of governmental response. Many of us were concerned about the disproportionate impact, right? So this comes from Allegheny County public data on their website. And this shows that there is a racial disparity. In this case, the Black-white disparity is 2.4 times for cases of COVID, right? So this is adjusted per population. And I just note here the sharp increase on that day period there had to do with some additional, I would say, algorithms and other data sources that partners between ACHD and DHS were able to use to fill in race data, because a significant portion of race data was unknown or missing, right? So we see, once again, not only the disparity, but the sharp increase, right? So here in Allegheny County, many of you know, we've had the sharpest increase in COVID cases across the state, right here in our county, right in this region, right? So not only are we talking about a state of emergency in general, we have obviously, a really dire situation in our county in terms of increase in cases, and then at the same time, disparity or inequity. These are tests. I wanted to show this, right? Once again, the sharp increase on that sort of day period had to do with them filling in missing race data, where actually the test per 100,000 population where Black residents in Allegheny County were actually more likely to receive a test compared. So it's about a 1.6 time. Part of the I wanted to show this was because part of the question is, well, does disparity exist because there's more testing among Black individuals per per, not in sheer numbers, but per actual population. And what we're seeing, at least from our initial sort of review of the data, is that it does not account for that disparity that we're seeing. Other disparities, just life expectancy, I gave you a couple around pregnancy and birth, and now I want to hear a couple from your own work, right? So many of you mentioned doing work in the area of cancer, generally speaking, but also touch points and other health outcomes. So if you can just share with me other disparities that you are familiar with, either from your work or other topics that you've explored even prior to this research experience.
I can go. I'm working with autism spectrum disorder individuals, and this isn't related directly, but police brutality is really, really deadly for Black children with autism. So I mean, like, it's really bad for that specific group.
Mm-hmm. Great, thank you. Anyone else?
I forgot like which cancer it was, but I think it may have been myeloma, but the outcomes for like African American patients was far worse than other ethnic groups.
Mm-hmm. Great, thank you. Anyone else? All right.
Well, sorry. I remember reading that a lot of times the initial prognosis in poorer countries, and specifically they were talking about Africa, the initial prognosis is much worse because they don't have the resources to like detect the cancer early on. So you see cancer in much later breast cancer much later stages in women from Africa and even like South Asia.
Right, so we're talking about sort of this confluence of testing and detection, and what are the potential factors that may contribute to that, right? Early detection. So then why do inequities exist, right? This is getting into the causes, right? We can talk about disparity, but why? Why does it exist? Right, anyone? So all the health outcomes that you mentioned, this is just one example, right? We talked about, I showed examples of Allegheny County COVID, Allegheny County pregnancy, looking at Black-white disparities. What are some of the reasons why these health disparities exist, these health differences exist?
So in the chat feature, Jonathan wrote wealth. That's why.
Wealth, okay. Thank you. Yes, chat, perfect, yeah. And I might need help because I'm trying to.
Yeah, Sam says feedback loops.
Feedback loops, what do you mean by that, Sam?
So it's like if one group is starts off in a situation where they're disadvantaged, like immigrants,
Okay.
then people are like, okay, they aren't like as good as us, or like they don't like we don't think that they can do as good a job because they what is it? Because they like didn't have this. They started off disadvantaged, and then that leads to just a second.
No, I understand. I have a
Okay.
pup too.
Yeah, and then
Yeah.
so even when they aren't beginning disadvantaged anymore, people don't like if you start off if you're born like it's sort of like the case of with like how homeless people have a much more difficult time getting a job because they don't look as like professional, or like they don't have the ability to shave or like groom themselves as easily, or they don't have as clothing that looks neat all the time, and then that makes it hard for them to get a job, and then that makes it hard for them to get a house to like not be homeless, and that sort of leads into this cycle where there's no way out without outside help.
Mm-hmm. I see. Okay, in terms of feedback loop. So I think a lot of what you're talking about are sort of these levels of influence from, policies that have exacerbated our homeless and insecurity around access to homes, safe and healthy housing, and sort of the effects as it relates to not only health, but as you're saying, economic opportunities as well, and this sort of relationship between all of those. Anyone else write anything else in the chat before I go on?
I think it also has something to do with like unchecked biases and healthcare providers.
Mm-hmm.
I've just seen a lot of stories about how African American women and their concerns aren't taken as serious as other as like white people.
Mm-hmm. Right. So what you're speaking of obviously is a lot of the work around how, medical systems, I would also say public health systems, dismiss the experiences of, Black women, as you mentioned, specifically as it relates to pregnancy and birth outcomes, but we see similar work in other areas, even outside of maternal child health. Absolutely. So this is just some examples of, yeah, go ahead.
Like I took a class called Human Geography, and we learned about like redlining and the white flight, and like sometimes like certain neighborhoods get better access to facilities and to professionals than others, and like stuff like gentrification, it excludes people who can afford to live in a certain area from the resources that that area provides.
Yes, absolutely. And some of my work actually speaks directly to that. So the ways in which structural institutional racism, both historically and contemporarily, have contributed to what you're talking about, right? Not only sort of access to resources, but what are the things that contribute to this differential access, right? From redlining policies to segregationist policies, to the explicit actions of Federal Housing Association, to what we see today, right, with respect to policies around displacement. Absolutely. So thank you for all of those. I think you touched on many things, right? We have these sort of individual things that we can think about, right? And I also venture you to really think about these community and structural related factors, right? That go beyond the individual, right? Because it's not to say that individual factors or individual behaviors don't contribute to health, but they're within a larger context. And when we're thinking about even the population level, those contexts are influenced even beyond, what we might see in the immediate, right? So just a quick question. I wanted to take a poll. You can, I guess, write in the chat, or if there's a poll option. What percentage of your health outcomes are actually shaped by access to healthcare? 20%, 50, or 80? I see some in the chat. So we have a lot of 80%, 80%, right? Anyone else? 20, 50. So our health outcomes, what you're saying is primarily shaped by access to healthcare, right? Is that what I'm hearing? All right, so I want to show you this model. Can you all see it? So many of you actually gave examples of social determinants, right? These larger contexts that influence our health, right? And there's a multitude of, I would say, reports and analyses that have been done to talk about, what are the contributors to health, right? And it doesn't mean that the healthcare system is not important, and it doesn't mean that access to healthcare is not important. But, according to this report, and there's also others that talk about what shapes health, and this demonstrates that only 20% actually are embedded in healthcare, right? Only 20%, right? And you think about how often do you go and interact with a healthcare setting, whether it's a clinic, whether it's your physician or hospital or freestanding birth center, for example, how often do you actually interact with the healthcare system, right? And many of the health issues, right, and outcomes that we contend with, all the things that you all mentioned earlier, happen even prior to getting to that clinic or that physician, right? Not to say it's not a piece of the pie, but it accounts for a small percentage. So for many of us in public health, we're really interested in looking at these larger contexts that we know influence health, right? And these are examples, right? When we think about social determinants, again, very much related to how we think about public health, or at least the definition of public health, right? Social determinants of health are conditions in which people are born, grow, live, work, and age, shaped by distribution of money, power, resources at the global, national, and local levels, right? We think about these spheres of influence, right? Individual, embedded within the social context, within these larger conditions, right? You talked about work environment, living and working conditions. Someone mentioned employment. We talked about water and sanitation, right? Housing, all of these things. So then how do we eliminate inequities? Like, that's the question, right? That's the question, right? We know that inequities exist. We know what some of the causes are. And even though research is continuing, does that mean we stop trying to figure it out or address it, right? But what types of actions do we typically take? What are some of the actions that we take, right? So if we believe that healthcare accounts for 80% of our health, everything we do is going to be focused on healthcare, right? When it's only a small piece of the pie. If we put all of our time, resources into healthcare, and actually that's the way our money is spent, let's be honest, right? Huge proportion in healthcare, huge proportion in new technologies, all that are important, right? But innovation does not mean that we necessarily innovate only in that sphere, in that space, right? When we think about the interventions affecting health, where do we spend the most of our time, money, and resources? At the top, right? Behavioral interventions, clinical interventions, healthcare. But what about those long-lasting protective interventions? What about changing the context? What about socioeconomic factors, which also, I would say, relate to structural factors, right? Policies, right? So if we were to sort of revisit the tiers 2 and 3, right? Tier 2, what is the cause? 3, how do we intervene? I want to flip the question a little bit, because first I asked you, why do these inequities exist, right? But if I were to flip this question, and I really get this from the work of a mentor of mine, Dr. Diane Rowley, who was one of the first researchers at CDC to do work around racism and pregnancy, worked closely, was a partner of Dr. Bill Jenkins and Mona Phillips, Fleta Jackson, all these folks who were in the maternal and child health space, and epidemiologists as well, doing work around racism and health, right? Some of the first researchers to really do this work. And the question flips, right? This is getting into critical race theory as it relates to racial disparities specifically. What is unique about those experiences? What is the lived experience of those people, right? Whether you're talking about Black people, African Americans, specifically Latinx populations, what is the lived experience of those groups that would cause them to get sick or die sooner? So it's a little bit different question, right? We're not just saying, well, why does the disparity here? Why does it exist? Why do we see this difference? But what is it about that lived experience, right? What is unique about that lived experience? So for example, focusing only on prenatal or clinical care in public health policy prescription, it ignores the socioeconomic context in which women live, and it medicalizes a problem that's socially, historically complex, right? Going back to, there's not this one silver bullet, but we know that prenatal care healthcare is not the main contributor to these adverse birth outcomes, such as infant mortality and preterm birth. And we could probably say the same thing for the examples that you all gave earlier, but also the examples of, what you talked about even before I got on this call around your specific research projects this summer. So this brings me to some of the work within the maternal health space, and some of you may be familiar with the Lost Mother series, the national conversations around maternal mortality. Specifically, we had, op-eds that were written, Serena Williams, other celebrities. My colleague, actually, Shalon, who passed away, who was an expert and researcher in this field and area, right? That, this notion that, well, if you were to get a higher education, then, everything would be fixed, right? If you were to continue on and get that degree, that is the sort of answer, that's the silver bullet, right? And that's what we've seen as well, right, within the field, to try to explain away why we see this difference. But then if we go back to the question of what is the lived experience for Black people in particular, Black women or birthing people, and why we see the adverse birth outcomes, right? Then that's when we're getting into what is that context, what is that experience, right? And that really draws on this work around racism, intersecting oppressions, right? Racism, classism, sexism, and how that relates to adverse outcomes. I like to give this example or show this example, and I also have I don't have the local data on this, right? But this notion that, well, with an increase in education, now obviously that we would see, improvements in birth outcomes. So this is national data. This was a report put together by researchers at Duke, where basically they show, and this is adjusted for age as well, that as you see an increase in education, there's actually a more stark disparity, right? So even if you were to look at those who are bachelor's degree and higher, right, just to pull that group, that doesn't explain the disparity. The disparity actually widens, right? These are folks who may be in higher level positions. These are folks who are obtaining, higher levels of their degree, and this disparity actually widens, right? But we have to put that data in context, right? And this is just one example of that. I like to use this example, and I think you all will have access to these slides and these resources here. But this really shows a timeline, right, of social experiences of African Americans and their descendants in the United States, with particular attention to sexual and reproductive health. So this actual timeline and paper really pulls out, I would say, some really broader aspects, even outside of sexual reproductive health, but then also things that are specific to sexual reproductive health, right? So when we look at the timeline, right, of legally sanctioned sexual reproductive violence, right, legally sanctioned, that to many will argue still continues, right? Negative stereotypes, limited civil rights. I think Amanda mentioned residential redlining, right, and segregation. Laws prohibiting formal education, and then also limited educational opportunities and resources, right? This is not only are we talking about the contemporary disparities that we see today, but they're within a historical context. I wanted to share this too, because this is just one model that a colleague and mentor of mine developed when we think about, well, how do we go about addressing it, right? I think the first thing we do is let's just provide some resources. Let's educate people, right? And it's not to say those things aren't important, but what this model does is it really lays out key elements that we need to consider, right? Before we just go on to actually provide, which is the P, the last thing, right? Repair the historical damage, right? So that timeline that I showed you, there's historical damage that has been done that has not ever been atoned for. And that's for not only the African descendant people that I showed you in that timeline, but indigenous people as well, and many other racial and ethnic groups within the United States, right? We're talking about our context here, right? Then we also talk about restructure, right? So we talk about where we live, work, and play, all those environmental sort of contextual pieces that influence our health. What are the structural changes that need to be made, right? whether that's policy, regulations, et cetera, right? To stop the new production of risk that will continue, right? So it's repairing and restructuring, absolutely removing. How do you remove those pieces? Remediate, right? So while structural changes are happening, because it takes time, it took 400 years for us to get to the place that we are, actually 500, right? So what do we do as those structural changes are being implemented to reduce risk? And then finally is provide, right? So before you kind of jump into, we're going to provide resources, these are some of the pieces that need to happen first. But even as you're providing resources, services, healthcare services, what have you, it needs to be attentive to the community in which those services are to be provided for, and also should be centered on what that community is saying it needs and wants. And in many cases, in most cases, those solutions are within the community. Many times those communities are already doing the work with limited resources and support to do it. So I want to leave you with just two short exercises, things for you to think about. We won't have time to kind of flesh it out, but it's something that I actually do with a lot of learners that I work with on the graduate level and undergraduate level, which is really being self-reflective. And I pose that to you now. I actually do this with practitioners as well in the field who've been in the field for a while, but also need to take note of how they're doing their work and in ways in which they're being complicit with respect to, racism, sexism, ableism, and really take that time to examine their own bias. So how might you address your own bias in your own work, right? Whether that's your research, whether or not you all want to move forward. Many of you talked about, moving forward in medicine or other related fields, right? And this goes beyond a cultural competency workshop, right? Many think, oh, I'll do a diversity training, I'll do one of these workshops and I'm all good. And really it's a commitment of self-reflection and critique over one's lifespan. So we can talk about self-reflection on the individual level, but then what does that mean in terms of the actual institutions that we interact with, right? How does your experience relate to your work and research? Public health being one example, right? That's the field that I'm in, which obviously is expansive and related to medicine and other areas that you all described earlier. But it affects the kinds of questions, topics, issues that you decide to conduct, the hypotheses and frameworks, right? Especially when you think about your research topic this summer, and then the types of analyses that you conduct. What types of analyses or approaches are elevated over others? And then finally, asking the question of how are isms operating here? Racism, sexism, classism, ableism, how is it operating? How is it operating in this institution, agency, and program? And what are the ways that I might be complicit, but also what are the ways in which action is needed? So I'll end there. I know we're at the hour, we're at 2 o'clock. I'll welcome any questions. You have my contact information for those who want to reach out and talk more. And I really, I'm thankful for this opportunity to meet you all and interact with you today.
Thank you, Dr. Mendez.
And Dr. Mendez, we do have one question from YouTube. And Megan asks, in regard to the R4P, what are some specific examples of ways you think we can start resolving disparities, like in IMR? Things we have done in the past or what we can do in the future? Absolutely. This is a great question. And this, I'll just note, and this is the citation for it, the scholar who developed this framework, who I work closely with. We were in constant dialogue about, how do we think about reshaping, the institutions that continue to run and move, and a lot of times it is sort of that shift while things are still carrying forward and going on and working. And so one of the things that I'll mention, which is not the end all, be all, but I'll start with repair as just one example, right? And I showed the historical timeline. What we've seen recently is here in the city of Pittsburgh, Allegheny County, modeled after Wisconsin, Ohio now, Minnesota, multiple cities, right, have moved forward with developing legislation of racism as a public health crisis, right? So actual legislation that says we acknowledge racism exists, and now how do we move forward with it, right? So obviously the legislation, it could be symbolic, right? Like, okay, you wrote that, now what? What is the next step, right? So that's just one example.
where, and one that I saw recently from Houston, where not only do they acknowledge, okay, generally racism exists, but they were very explicit on how it has operated in the city of Houston with explicit examples in that legislation. And I think that's important because if we're not ready to acknowledge how those things have manifested even historically and today, how are we to move forward with those decisions? I think it also, could be related to our own institutions. When I do work in collaboration with community, I'm very clear that I know that University of Pittsburgh, UPMC, that they, have had a historical relationship with community that has not been great in many ways, that has been out of exploitation. And so really acknowledging that as well. Obviously, I'm not responsible for all of that, but I carry that with me as a faculty member who is attempting to do community health work in collaboration with community and support of community. So I think that that's just one element that I've seen in terms of the recent legislation. Another key component as it relates to remove is what I've seen in the maternal child health space is development of legislation that also names racism and other forms of oppression, and specifically has processes for going through all of the policies that might exist in that organization, right, or in that framework, to say, how is it operating here? How is oppression operating here? And then how do we remove it and stop it? So those are just some examples. We could probably go on and on, but that's a couple. Any questions from the learners, scholars here on the call? None, you are so quiet. Well, as I mentioned, I'll just scroll back down to the last slide. Feel free to reach out if you have questions. Taylor knows how to get directly in touch with me as well. And I look forward to hearing about all the great things that you are going to do this summer and beyond.
Thank you so much, Dr. Mendez, for this enlightening talk. And if you send Solomon or myself the slides, we'll be sure to get them to the students as well.
Absolutely. I'm going to stop sharing.
Great. So thanks, everyone. I know some people have had to run to meet with mentors and things and signed off right at 2. For the rest of you, thanks for participating. Again, I know in this virtual world, it's a lot more difficult, but thanks for engaging. And I will see all of you tomorrow, where Taylor and the other 3 Doris Duke undergraduates will present a journal club as an example for all of you. So I will see you all tomorrow.
I have a question, a really quick question before you go. So you were talking about the 4 R's and how under repair, making racism a public health crisis, codifying that into law. But let's say that is law, and now you're legally allowed to challenge that in the court. How do you get around the fact that the people who are the deciding factors, the judges and the people involved in law enforcement, are predominantly white, and that's changing, but still, so how will that be solved?
No, it's a great question. And, that legislation that we've seen across cities, counties, and some states is not, I would say, the end all be all, because there are a multitude of layers and levels. Some of the legislation actually does speak to that it's not enough to just put this law on the books, but what does it mean with respect to the things that you're talking about, right? Across multiple systems. And it's framed in a way where, in most cases, we're talking about health and all. So I used that language a little bit earlier, that that almost everything that we do or interact with has some health implications to it, right? So if you talk about the intersections between health and well-being in the criminal justice system, one of the scholars mentioned earlier that they're looking at that relationship, right? That's one system, right? The criminal justice system, right? In terms of how racism and oppression is embedded in that system and what that means, right? Whether that's the judge, whether that's the DA, whether that is, police sanctioned violence against Black and Brown communities, right? So there's multiple levels there. Someone mentioned housing, right? Historical and contemporary racism and oppression and how that relates to housing access, right? Someone mentioned wealth a little bit earlier, right? We think about home ownership, that's one way to carry on intergenerational wealth. And specifically, you know, Black families were, you know, kept from many of the opportunities to own homes and to carry that wealth forward in their families, right? So those are, yeah, you absolutely bring up an important distinction that the laws that were developed, or at least the way in which they're articulated now from the ones that I've seen, and many more are being developed. I think we're seeing a tipping point of, you know, naming it, but I think it goes beyond that, as you're saying. Thank you, absolutely.
Excellent. Taylor, do you have any other things you would like to mention before we leave?
No, well, I'm not really sure what the time frame should be, but I feel like the students might have other meetings to go to, but if anyone else has other questions, or Dr. Mendez, if you still have time.
Yeah, I can hang on.
That would be a good time.
Yeah, absolutely. I wasn't sure if we're still live or streaming, but yeah, I can hang on for anyone else who needs to jump off, and folks who want to stay. I know it's a little odd asking questions live when everyone on YouTube can see you.
Yeah, and we have now stopped broadcasting and recording.
Okay.
And there were about 15 people on YouTube.
Okay.
So not a huge audience, and that's about what we're seeing. Yeah.
But it's archived, so someone can watch it later, correct?
That's true. Yes.
Yeah, I think we had like 50 people watch our first video.
Mm-hmm.
So it's getting to some people.
Mm-hmm.
Well, maybe as a final question, do you have any other resources that high school students should look into to familiarize themselves with public health, or to learn more about inequities in our society?